Hello, my name is Daniel Davis, and thank you very much for the opportunity to contribute to World Delirium Awareness Day. It's a really key event in raising awareness of delirium, both for clinicians, researchers, um, policymakers, educationalists, and it's great to have a focus where cumulatively we can all work together on this really critical topic. I'm using this talk is going to be about how to define delirium for a clinical research study. Many people ask me, what's the best way in which to define delirium when you're doing your own research, and so I wanted to share some of our experiences on this. I'm an epidemiologist. Ultimately, there are many approaches to how you define delirium in a clinical research context. And it will be, there will be always be a trade-off between, well, firstly, it will be principally driven by your study aims, exactly what you're trying to establish. There will always be a trade-off between the intensity of research measurements that you can undertake and resource enabled to do it, and also patient tolerability for those things. So that's sort of the art of epidemiology, if you like. But we did, I've been running the Delirium and Population Health Informatics cohort, the Delphic study, since 2017. And the aim of that is to provide detailed epidemiological description of different brain symptoms when older people are admitted to hospital. So will be more detailed potentially for many of our purposes. But I think it establishes some important principles that are relevant to all studies. Okay, so it all starts with a reference standard. And I've got DSM-4 here. It doesn't matter if you choose DSM-5 or any other one, because broadly they all overlap anyway in terms of exactly what they're trying to describe. The key thing is that ultimately what we did was collected enough data that you could generate a DSM-4 or a 5 or a 3R or an ICD-10. It didn't really matter because we connected enough base data that different definitions could be, you could slot in different standards, if you like. But broadly the reference standards do agree. The DSM-4 has the one with the most research literature attached to it, even now. So it's a good one to go for. And it's got these four characteristics: disturbance of consciousness. Yeah, normally we talk about level of consciousness, i.e., arousal, and content of consciousness. These two things that become clouded, the cardinal symptom of delirium, and they're hierarchically related, so that if you have an abnormal level of consciousness, i.e. arousal, it may not be possible to assess the content of people's consciousness, but that's still extremely important finding to make the case that someone has delirium, even if they can't, for example, speak because they're so obtunded. You need to demonstrate a change in cognition, and the small print says cognition and or perception. Delirium should be acute and it fluctuates, and it should be driven by a physiological precipitant. And that's all very clear, especially this criterion D, because that distinguishes, you can forget A, B, and C fulfilled in other presentations of altered mental status, for example, Lewy body disease. I'm just going to unpick it a little bit because the operationalization of any reference standard is basically about unpicking and defining how much of these things have to be abnormal for you to call it, an abnormality. So physiological precipitant is actually quite difficult because sometimes you don't prospectively know exactly what the precipitants are. So practically, what do? We normally assess people. We normally say that this is abnormal. We correct them, and the next day they're better, same or worse. And so clinically, we just sort of empirically work out what the precipitant was or is. And so it's important to bear in mind that you may not be able to apply exactly what the cause was or cause is, more commonly, until after the event. Yes, delirium is acute and fluctuates. No one disagrees with that. Typically, the time frame for that is over hours and days. But it may be that there's delirium that could evolve over a week, 2 weeks. Could there be delirium that subacutely evolves over 6 weeks, especially if you've got underlying dementia? I mean, the textbooks don't tell you, and so for a researcher, you have to just decide this is what we're going to define acute as. And of course, acute onset, Yeah, but acute, often the time frame for recovery isn't acute, and we know that delirium can linger for days, months, and even never recover. So again, this is about applying empirical data to really understand what these domains are and how you define them. Change in cognition, very tricky as well, because again, the textbooks don't say how much of a change constitutes a change. Is it 1 MMSE point, or is it, 15? It doesn't, no one tells you what that threshold is or shouldn't be. And the key thing is that, for all of these domains, is that you do it in a standardized, reproducible, and consistent way across your team, all the people who are involved. And disturbance of consciousness, as I said, typically arousal, definitely arousal, and definitely some test of attention. So when you tie that all together, these are the component parts of a delirium assessment framework. And I can tell you what attention tests we used. We used a variety. We used digit span, we used monthly backwards, we used serial sevens, we used arousal tests, we used the Osler, general cognition, we used things, components from the MDAS as well as other items. We did it daily, Monday to Friday, all of these things we define. It doesn't matter exactly what we did, as long as you choose good measures that capture these domains and bake them in to a protocol that everyone can share. And of course, there's an adjudication panel for and some mechanism of dealing with, I wasn't sure. This was a difficult assessment. They said this, but I know that they also have depression. How are we going to score this? And sometimes that's really helpful to have almost in real time, but sometimes you need to take stock of difficult or challenging cases, and then you need a process for that. And of course, driving all of that, therefore, is a strong component of education and training, so that everyone who's doing the same thing does it in the same way. In epidemiological studies, it's worth really just emphasizing that your power is exponentially related to the precision of your outcome measure. So the more efforts that you take in tightening that up, it will pay many more dividends than just increasing sample size. So sample size gives you linear increase in power, but exponential increases in power come from really being as exact as possible with your reference, with the precision of your outcome measure. Another epidemiological principle that's relevant is misclassification bias, and especially in delirium where there's fluctuations. And the key thing is here, if someone doesn't have delirium and they don't really have any change in mental status, whereas a true delirium has this sort of blurriness that waxing and waning, but you only happen to go fishing at certain times and don't catch anything, then the frequency of your outcome measure will again lead to under-coding of the delirium, and therefore you lose again power. So not only is the precision a cross-sectional thing, i.e. everyone's doing the same thing for each assessment at that time, it's also there's precision that comes from something that fluctuates like delirium, that means that the more that you can do, the better. As I said to you, there's always trade-offs in epidemiology, and I sort of hinted at one before, which is that we were only able to do clinical ascertainments Monday to Friday, and sometimes there's bank holidays, Christmas, and so on. So, if we had more money, I could have had a team that was going to get paid overtime to work weekends and stuff as well. But that was just, so we had to. So when we've come to look at serial measures of our delirium case ascertainment, we've had to make some assumptions about information from a Friday assessment and how that links to a Monday assessment, and kind of like imputing bits in between, which again there are which has assumptions that underlie it. It's not wrong or right. It's just something that needs to be justified and thought about in advance. In terms of confounding, this is a really important idea if you're interested in connecting delirium to some other either cause or consequence of that delirium. So what I mean by that is that if you're delirium is associated with pretty much all patient safety outcomes. So you're interested in, say, inpatient falls, aspiration pneumonia, increased length of stay, higher mortality, higher institutionalization, more rehabilitation needs, etc. That's why, let's say that you're interested in understanding delirium's impact on those things. Well, because delirium always has these two things, these precipitating factors and predisposing factors, you need, and of course we know that these are related in an inverse way, so that if you have high degrees of cognitive impairment and frailty, then it's trivial physiological precipitants, like the Jenga falls over very quickly, or if you're young and not frail, then the precipitating factor is proportionally greater. So we know that, but what that means is that if you want to say that delirium is associated with some bad thing follow-up, then you need to be able to say that it was independent of these two domains, so that so that those bad things weren't just because they were sick or just because they had dementia as well. If you want to estimate the independent effects, it's only these are not causal; these are observational data. Then you need to have measures for all of those things, not just the delirium, but the predisposing factors and the precipitating factors. And that is also not completely unproblematic, because when you're trying to operationalize the risk factors for delirium, well, predisposing factors, you need to think about cognitive factors, you need to think about functional predisposing factors and their sort of comorbidities. We were able to do this very precisely in Delphic because we actually measured these things prospectively before they even got sick. But that's how we solve this problem. But you can there are ways of getting retrospective measures of people's cognition. IQ code is an example of a dementia diagnosis that can be applied using informant histories. Others are available. Again, sometimes you can get a good measure of someone's IADLs from an informant history too. Not as reliable as prospectively, but it's not nothing. Again, exactly what one uses, it doesn't matter. What I'm trying to articulate is that if you follow a framework, then it's something that that you can think about. How have I justified each of these things that I'm doing? And that should just keep everyone straight, in terms of how we understand delirium and its clinical impact. And precipitating factors are very difficult as well. You've got physiological, how do you measure how acutely unwell someone is? Or we've got different scores and things. But, and this is really at the heart of the matter, is that although we have measures of them, do they actually adequately account for the measures of interest? And are they really validated in older populations? One thing that I'm still not really sure about is, for example, physiologically, if someone has, you can get composite early warning scores, like composites of blood pressure, oxygen saturations, and heart rate, and so on. Yeah, sure, but and that's very accepted to be, if you have a high, what in the UK we use the NEWS score, but it means you're acutely unwell, and that, but is the heart rate of 110 in someone who's 90 with a pre-existing frailty index of 0.5, is that really the same as someone else who's much fitter sustaining a higher heart rate? Again, these things aren't really, the epidemiology of this is still not completely we don't have great natural history data on all those things, but in the art of the compromise, you measure what you can as best you can. And again, how able one is able to do this will be a function of your research question and your resources. So I want to just summarize that by saying, really important to work from the reference standard. The timing and frequency of observations is critical. All of this needs formal training, adjudication procedures, so that we again, it's all about getting that very, very as tight as possible operationalization of the reference standard, and then of course measure precipitating and predisposing factors as best you can. Okay, that's all I have to say. I'm very happy to take other questions. I'll be joining in a live chat at various points throughout the week, and very happy to take questions and so on by email or Twitter and so on. So thanks very much for your attention, and enjoy World Delirium Awareness Day.